Today, we are jumping right into a huge state-of-the-art review from the BMJ all about managing obsessive-compulsive disorder, or OCD, in adults. Now, this is a really complex condition, so we're going to get straight to the evidence-based treatments and the cutting-edge innovations that are really changing the game for patient care. So here's our roadmap. First, we're going to define what OCD actually is. Then we'll cover the standard treatments that are being used right now. After that, we'll dive into the exciting new progress in both psychotherapy and biomedical approaches, and we'll wrap it all up with the most important takeaways from this whole review. All right, so let's get right into it. First things first, what is OCD really? Truly understanding its core components is absolutely essential for getting a handle on how it's treated. At its core, OCD really boils down to two things. First, you have obsessions, and we're not just talking about everyday worries. These are persistent, unwanted, intrusive thoughts or images that cause a ton of distress. And second, you have compulsions. These are repetitive behaviors or even mental acts that a person feels like they have to do to try and get rid of that anxiety. And you might be surprised to hear that this is not a rare condition. Not at all. The data shows that about 1 in every 40 adults will experience OCD at some point in their lives. Think about that. And yet, even though it's so common, it can often go undiagnosed for years. So let's talk about the engine that keeps OCD running. It all starts with a totally normal, intrusive thought. The kind everyone has. But for someone with OCD, that random thought gets misinterpreted as something dangerous or catastrophic. That misinterpretation creates intense anxiety, which then triggers a compulsion to try and fix it. And while that compulsion gives a little bit of temporary relief, it actually reinforces the idea that the thought was dangerous in the first place. And boom, you're locked in this vicious, self-perpetuating cycle. So that's the cycle. The big question is, how do you break it? Well, that brings us right to our next section, the current standard treatments, the evidence-based pillars of care. When it comes to psychological treatment, there is one that stands head and shoulders above the rest. It's a specific type of cognitive behavioral therapy called exposure and response prevention, or ERP for short. And this is, without a doubt, the gold standard. So how does ERP actually work? Well, it's a pretty structured process. First, patients get educated on OCD and the logic behind the treatment. Then comes the exposure part, where they systematically and gradually face the thoughts and situations they fear. But here's the real kicker, the most important part. They do this while practicing response prevention. That means they consciously stop themselves from doing the compulsive ritual. That's how you break the cycle. And does it work? Oh yeah, the results are incredibly powerful. Study after study shows that patients who stick with ERP see a whopping 50 to 70% reduction in their symptoms. That is a huge, life-changing improvement that tends to last long-term. Now, therapy isn't the only tool in the box. On the medication side of things, the primary first-line treatment is a class of drugs you've probably heard of, selective serotonin reuptake inhibitors, or SSRIs. So let's put these two head-to-head. How do they really stack up against each other? The numbers here tell a pretty clear story. For ERP, the effect size is considered large, leading to that massive 50–70% symptom drop. For SSRIs, the effect size is more in the small to medium range, which translates to a more modest 30–40% reduction. So yeah, medication can definitely be helpful, but the data is crystal clear. ERP is the more powerful intervention of the two. But science never just stands still, right? So let's check out what's new and evolving in the world of psychotherapy beyond just standard ERP. What's really cool is that researchers are exploring a bunch of different avenues. Some are looking at ways to make ERP even better, like with the inhibitory learning model. Others are bringing in different frameworks entirely, like acceptance and commitment therapy, or ACT, which is all about building psychological flexibility. Then you've got inference-based GPT, which hones in on the specific reasoning mistakes that fuel obsessions. And of course, telehealth is making all of these treatments way more accessible to people everywhere. And that point about telehealth, it's a total game changer. I mean, think about it. Therapy isn't just stuck in an office anymore. A therapist can now virtually be with a patient in their own home, guiding them through exposures in the exact environment where their symptoms are the worst. It makes the treatment so much more real-world and effective. Okay, so we've talked a lot about psychological treatments. Let's switch gears now and look at the biological side of things. For folks with really treatment-resistant OCD, these new biomedical methods are offering some serious hope. So on the medication front, researchers are looking past serotonin to other brain chemicals like glutamate, Though, to be clear, the evidence there is still pretty early. But where we have much stronger support is with something called neuromodulation. For instance, repetitive transcranial magnetic stimulation, or RTMS, is a non-invasive way to use magnetic pulses to stimulate key brain regions. And for the most severe, hard-to-treat cases, there's deep brain stimulation, or DBS, which is an invasive surgery but can be an important option. And of course, we have to talk about one of the hottest topics in psychiatry right now, psychedelics and dissociatives. We're seeing early studies suggesting that psilocybin might help break those rigid, repetitive thought patterns. Ketamine can offer a really rapid relief, sometimes within hours. And there's even interest in how MDMA could help make therapy like ERP more effective by boosting emotional openness. Now, this is all still very new research, but it's a truly fascinating frontier. Phew, okay, we've covered a ton of ground here, from the gold standard all the way to the cutting edge. So let's boil it all down. What are the absolute most important take-home messages from all of this? The best way to think about the clinical path for OCD is as a step-by-step approach. You start with the heavy hitters, the first-line treatments. That's ERP and SSRIs. If a person doesn't get the results they need, you move up to the second step, which could be different meds or newer therapies like ACT. And for those who still struggle, you can then consider third-line options, like RTMS or even DBS. It's a clear, logical, evidence-based roadmap. So let's hit the highlights one last time. First, and this is the big one, ERP is the most effective first-line treatment, period. Second, SSRIs are also a first-line option, but they are just not as effective. Third, we have exciting new options on the horizon, from therapies like ACT and ICBT to neuromodulation like RTMS. Fourth, care has to be personalized and culturally aware to really work. And finally, the search is always on for even better ways to help those with the most treatment-resistant cases. And all of this leaves us with a final, forward-looking question. The future of treating OCD probably isn't about finding one single magic bullet. Instead, it's about figuring out how we can skillfully combine this whole toolkit of established and innovative treatments to create truly personalized care that improves life for absolutely everyone affected by this disorder.